and hear you. So I was surprised that nobody was looking at me or talking to me. Now I realize I was not connected. So I'm glad it finally worked out. Okay. Today, we're going to talk about the borderline personality disorder. It's the first of the personality disorder about which we are going to talk in detail in the series that is starting with this one today. I would first briefly give you a history of the concept. The term borderline emerged in the 1930s, 1940s to talk about patients who seemed neither neurotic nor psychotic, but somewhat in between, poorly defined, and regarding whom it was not clear whether they could be treated and how. This changed only in the 1960s, in which simultaneously John Gunderson and his team at Harvard were trying to describe the phenomenology of the personality, while I myself, with our team, first at the Menninger Foundation and then in New York at Columbia University and Cornell University, we developed the structural concept of the pathology. In other words, trying to describe the psychological structures typical for this group of patients, rather than simply describing the phenomenological aspects of it. This parallel development continued for a number of years until it became clear that the phenomenology of the borderline personality disorder, as Gunderson described it, really corresponded to a definite group of patients who could be differentiated from other severe personality disorders. And at the same time, we were able to describe that the underlying basic etiology and derived from the structure of identity diffusion. And we defined identity following the earlier work of Erik Erikson. Identity diffusion is different from identity crisis of adolescence, and reached a description of the personality really synthesizing both phenomenological and structural aspect of it. And nowadays, I think we have a clear picture of the basic structure that is in common with all other severe personality disorder, and constitute it, and is represented by lack of normal identity integration or identity diffusion, and symptoms that derived from that, so that the structural concepts and the descriptive ones have gradually emerged in an integrated view of the personality that I will present to you. The most recent empirical work has been by Carla Sharp, whose analysis of personality disorders demonstrated that they have a basic common general factor in addition to specific one that separate the various severe personality from each other, and her general factor really corresponds practically to the syndrome of identity diffusion. So the structural concept of the illness is now what we consider as most interesting. And in fact, in the classification of mental diseases of DSM-5 and ICD-11, the pathology of self and relations to other is seen as the basic common structural characteristic of severe personality disorders, reflected clinically in the syndrome of identity diffusion. And in our past seminar, we talked about the structural interview as a diagnostic interview that permits the diagnosis of identity diffusion, severity, therefore severity of the personality disorder, to which can be added the specific personality aspects that differentiate borderline personality disorder from other personality disorders. The importance of this structural concept is that it is the structure of the personality disorder, whether it occurs in patients with severe identity problems, identity diffusion, or in patients with normal identity integration, whom we consider to have a neurotic personality organization. The difference between these two groups of patients is enormous in terms of treatment, prognosis, and therefore the structural analysis is really fundamental in placing borderline personality disorder in its relation to all other personality disorders. And it is important to keep in mind then that we use the term borderline both for the specific personality disorder that I'm going to describe today, and for the general grouping of severe personality disorders who present borderline personality organization. So borderline personality organization reflected by identity diffusion or lack of identity integration is the common feature that differentiates severe personalities from less severe personalities, with neurotic personality organization in contrast to borderline personality organization. And so in our diagnosis, we have to make that clear distinction between borderline personality organization common to all severe personality disorders and borderline personality disorder as one of these severe personality disorders. The first point is the need to make a diagnosis of the structure of the patient. And I shall remind you very briefly that in the structural interview, what we do is first study all the symptoms that the patient has, and that will differentiate his specific personality disorder from all others. So first step of the interview, complete assessment of all the symptoms that the patient has. Second step of the structural interview, to analyze the severity of compromise of the present personality functioning. We study the present personality functioning by studying the patient's relationship to work and profession, love and sex, social and family life, and management of free time and personal creativity. I repeat, we inquire from the patient how he's functioning in work and profession, love and sex, social and family life, and his employment of free time and development of creative initiatives that gratify him. Once we have gotten that information, which gives us clearly the particular personality alteration and permits to make a pretty accurate diagnosis usually of what category, what type of personality the patient belongs to. We go to the third step, which is studying identity. So first symptoms, then functioning in the present personality, then we study identity. And as I mentioned in the earlier lecture, we study identity by asking the patient to describe the two or three most important persons in his present life, so that in a few minutes he can give us a brief outline which can give us a sense of what is essential in the way in which the patient sees these persons. And after we have asked him that, and we evaluate whether what he presents to us is a coherent, integrated view of these two or three others that he's describing, we ask him to describe himself to us in a few minutes, to tell us what is essential about him, what makes him a person different from everybody else. And again, we evaluate to what extent we get a coherent description of himself or a chaotic one that cannot be really understood as a concrete person that emerges in the examiner's view. And so we conclude, if the patient has been able to present an integrated view of significant others and an integrated view of himself, that identity is normal, that the patient has a normal identity, therefore does not have borderline personality organization and has a neurotic personality organization, which is very important therapeutically and prognostically. So I repeat once again, the interview, the structural interview, which may take at the minimum 45 minutes and may take up to 2 or 3 interviews of that duration, starts out with complete evaluation of all symptoms, then evaluation of the present personality, then the evaluation of identity that I just described, and finally, in patients who show some peculiarity, strangeness in their behavior in the interview, or in their affect in the interview, or their way of talking, their language, or their thought content, we tell the patient at the end of the interview that what seemed strange to us, and see whether the patient is able to empathize with our experiencing one aspect of his presentation as strange. If the patient is capable to empathize with our view and gives us an explanation of his behavior that makes it more reasonable or acceptable, reality testing is normal. The patient is not psychotic, does not have a psychotic personality organization. If the patient is unable to empathize with ordinary criteria of social reality that we present to him in telling him how we perceived him in the interview, if he's unable to see that and to the contrary gets more disorganized when we confront him with that, reality testing is lost and the patient has a psychotic personality organization. So with a structural interview, we differentiate normal and neurotic personality organization, who are the same, borderline personality organization with identity diffusion, but normal reality testing, and psychotic personality organization, which means a psychotic structure that may correspond to a beginning psychotic illness, to a psychotic illness that is latent, or a disposition to regress easily into psychosis, all of which is relevant for treatment and prognosis. But patients with a psychotic personality structure may still function on a borderline level, but we have to keep in mind that the underlying structure is a psychotic personality organization relevant for treatment and prognosis. That is what I would like to mention as the most general way to go about the diagnosis, and in the course of carrying out such a structural interview, and of course later on, of course, in all other things that you get to know about the patient, you are able to formulate the full picture of the borderline personality disorder. A few words about etiology. The fundamental etiology is the lack of integration of early experience, is sharp split between idealized and persecutory aspects of internalized object relations. In other words, a split presence of idealized internal relation between an ideal self and ideal object with gratifying relations with the environment, sharply split from frightening, dangerous, terrible view of a hostile environment with predominance intense aggression in the representation of the other and of the self. And the incapacity to integrate these totally contradictory experiences is the essential problem of borderline personality organization. So at the end, the most important etiological feature is such a dominance of negative emotional experiences that the intensity of them prevents the normal integration of good experiences into an integrated view of self and an integrated view of significant others. So it is a predominance of aggressive elements of subjective experience. In our contemporary analysis of neurobiological functioning, we would say that the negative affect systems strongly predominate over the positive affect systems. The basic affect systems of the organisms are attachment, erotism, and play bonding. These are the positive affective dispositions that determine ideal relation between self and others. The many affects and experiences of attachment that are so dominant in the earlier state of living, in the experience of the baby, the erotic, which already emerges with birth, but gradually becomes more and more important through the life of child and adolescent and adult. And play bonding as the playful interaction with other members of the same species, the search for positive affiliative relationship that are not attachment, not dependency, but a playful interaction with equals. A combination of these three major affect systems is what, in fact, Freud called libido. He didn't know that his basic drive, libido, was really a composite of inborn affect systems that were the primary motivators of behavior toward what is good, away from what is bad, guiding the organism in the experiences in the world with significant others. If what predominates, on the contrary, are the negative affect systems, which are fight, meaning aggression, with rage as a base affect and all other negative affects connected with it, anger, irritation, resentment, envy, etc., as part of that system. Flight, which is escape from danger that one cannot dominate and control, such as destroying bad things through one's own aggression. If that's not possible, one has to escape. The origin of all kinds of anxieties and fears, the most important signal that the individual experience himself or herself in situation of danger. And in addition to fight and flight, the third negative affective system is separation panic, response to an extreme danger to survival. It's an emergency affect system that occurs when one's very existence seems to be threatened, and leads to a general paralysis of one's functioning, and is the origin of what later becomes depression and depressive illness. If there is a dominance of the combination of these experiences, fight, flight, risk of separation panic, that means dominance of aggression in the experience of the individual. And if that is excessive, it's not possible to reconcile it, integrate it, normalize, tone it down into an integrated view of oneself and significant others. This sharp split then determines identity diffusion, lack of integration of the concept of self, lack of integration of the concept of significant others, and all its consequences. Now, that excessive dominance of aggression has many causes, and we can summarize them briefly. By saying that there is no single pathway to the etiology of borderline personality disorder, but a combination of genetic disposition that involves hyperactivity of the negative affect systems that I mentioned, abnormal negative affectivity, affective and disposition to aggression is response to lesions and attack, and an abnormal control of affects, decreased normal capacity of cognitive control of affects. Affect systems originate in the limbic system, the central part of the brain. Cognitive functions are controlled by the cortex, particularly prefrontal, preorbital cortex, and consist in the organization of perception, the integration of a cognitive schema of the world that surrounds us, and a cognitive schema of one's own affect and the situation that activates them. And this and the general reactivity of the organism or temperament. So excessive disposition to negative affect activation that in turn may, due to failure and development of some neurotransmitters, is one major cause. The second major cause is the development of abnormal object relations from birth on. Very important is abnormal attachment because of failure of mother's attunement, capacity of attunement to the affective states of the baby. The existence of severe neglect, abandonment, trauma, and abuse, physical and psychological, from birth on, so that in addition to abandonment and lack of a normal development of mother-child relationship in the first months and years of life, there is a particular pathology of attachment that evolves, and that then is expressed in the incapacity to integrate positive and negative segments of experience, idealized with persecutory aspects of experience. So that, in short, the etiology of the borderline personality disorder is excess of aggression derived from genetic causes, from excessive activation of negative affect in the first month and years of life, for painful physical illness, trauma, abuse, neglect, and particularly pathology of attachment. So this is important when parents wonder whether they are to blame for the difficulties of their children. They are not to blame. The causes are multiple, both genetic, temperamental, affective, and psychological that derive from many sources and not only from the behavior of the parents. But all these causes then jointly signify dominance of aggression, and that shows in the symptoms and adaptations of the patients to reality. That's what I want to say about etiology, about the gross diagnosis of the severity of illness by structural interviewing and defining whether the patient has a neurotic, a borderline, or a psychotic personality organization. And we have briefly talked about etiology, and now we'll go into the description of all the symptoms. And the interest of the borderline personality disorder is that it's the disorder in which identity diffusion shows in the most complete and rich way. So they really have all the symptoms and difficulties that other personality disorders have only partially. It's a wonderful collection of the most significant and most severe symptoms. So that makes for great interest, but also for diagnostic difficulties. What are the main symptoms? From a purely descriptive viewpoint, phenomenological viewpoint, contributions of Gunderson and his group, as I mentioned to you. Fear of abandonment, unstable and intense relationships with others, fluctuating between ideal and bad relationships in a chaotic way, a disturbance of the sense of self, and not having a clear sense of self, and not being able to achieve a clear sense of what others are as personality, with failure in the normal identification, what's essential in what one wants, what one feels and what one wants, and what to expect from the other person, leading to chronic difficulties with others. Impulsivity, meaning incapacity to control affects. Normally, effortful control is one cognitive function normally developed by the cortex, particularly the prefrontal and precortical aspects of the cortex, the anterior part of the cingulum, and the insula, for those who are interested in the neurobiology of the structure of self and the representation of others. Recurrent suicidal behavior, which makes for important differential diagnosis. Instability of manifestation of affect, a chronic sense of emptiness and lack of clarity of motivation. Inappropriate anger, easily triggered and excessive in intensity and duration, and transient paranoid ideation or dissociation, transitory false suspicion of others' behavior, and dissociative experience. In other words, experiences as if one had changed and were not the usual self, but had the oneself all of a sudden were different. Depersonalization or de-objectalization. In other words, the world suddenly seems to be different, as if it had changed. These are the two main symptoms of dissociation, in addition to the possibility of complication by truly dissociative identity disorder. In other words, by development of multiple personalities under extreme cases that may appear as a complication of borderline personality disorder. These are the descriptive symptoms. From the dynamic analysis that we did studying the structure of identity diffusion, of course, the main finding was severe identity disturbance in the representation of self, the representation of significant others, and consequence, uncertainty, chaos, and contradictory interpersonal behavior is a permanent feature of these patients. The development of primitive defensive operations, in contrast to the mature defensive operation that are typical for neurotic patients with good identity. We talk about the high-level defensive operations as those that were described by Freud studying the unconscious and the mechanism to maintain the unconscious repressed. So repression, reaction formation, negation, intellectualization, rationalization, projection, all these are mature defenses in neurotic structures. They don't show in the diagnostic interviews, they show in the treatment. Primitive defense mechanisms are those that show typically in patients with severe personality disorders, with identity diffusion, and with psychotic structures as well. The essential one is splitting between idealized and persecutory internal states, reinforced by mechanisms such as projective identification, which is not only attributing something one can't accept in oneself to the other, but a combination of attributing to the other, inducing it into the other, trying to control it in the other, and maintaining empathy with what is projected. So it is a primitive, full-blown version of projection, what we call projective identification. So splitting is reinforced by projective identification, by very primitive types of idealization and devaluation, and efforts at omnipotent control of significant others to avoid any dangerous action coming from them. And denial is remembering something totally opposite that patients have done or experienced in the past, other than in the present moment, but with which they have no emotional contact at all. In contrast to regression, it's not out of consciousness what they can't accept as belong to them. They may be conscious in their memory that they had such a reaction, but it is as if now they have nothing to do with it. Denial is denial of the emotional reality of aspect of the experience. So these patients show in their behavior, because it shows the manifestations of splitting, projective identification, primitive idealization, primitive devaluation, omnipotent control, and denial. Their reality testing is normal, as I mentioned, but it is restricted because they miss the subtle ways of understanding social functioning. So there is a loss of the understanding of the subtlety, the non-verbally explicit understanding that goes on between people who are involved with each other. And that makes them inappropriate, clumsy in their social contacts, in spite of the fact that they maintain reality testing. They show what has been called ego weakness, which is a combination of lack of impulse control, the impulsivity, lack of anxiety tolerance. Whenever they get anxious, they tend to fall apart. They can't tolerate living with their anxiety. And weakening of their sublimatory potential, of their capacity of using their time for creative aspects that interest them. So that combination of loss of impulse control, lack of anxiety tolerance, and absence of creative endeavors or interests is a typical manifestations of these patients. They have therefore limitations in their social life, in their relating to people, in their creativity. And this shows also in work uncertainty whether they are into what they are interested. Very often they don't know what kind of work or profession they want. There are great difficulties, shift in work, poorly functioning in the work itself and in the human relationship that one establishes in the course of work. They manifest excessive, aggressive responses to negative stimulation, are easily triggered to become excessively angry. And some of them may show failure in the development of their moral functioning, weakness in their superego function in psychoanalytic terms, which makes for worse prognosis. In general, the two most important prognostic indicators in all kinds of psychotherapy are the severity of antisocial behavior and secondary gain of illness. The more there is secondary gain and the more severe antisocial behavior, the worse the prognosis. So we usually, when we start treating patients, try to control secondary gain at the beginning of the treatment and try to control their antisocial behavior as well. As you can see, the combination of these descriptive aspects and dynamic aspects gives you the full picture of the borderline personality disorder. When we started studying these patients, we carried out factor analytic work of our own. John Clarkin combined all these criteria in a study of the organization of these features, and he found out in his study that the major factors were identity diffusion, which didn't surprise us, affect dysregulation, and impulse control. Identity diffusion is the main pathology, expressed as dysregulation of affect for both excessive development of negative affect and failure of develop in the normal cognitive control functions. And we, in our neurobiological studies, we were able to demonstrate the hyperactivity in these patients of the amygdala, major source of negative affect systems, and the inhibitory function of the precortex, prefrontal and preorbital cortex, that would be the locus from which effortful control of affect expression would emerge. This really reinforced our clinical and theoretical orientation for the study of personality disorders. Differential diagnosis. The most, as you see, there is a multitude of symptoms, but always keep in mind the essential one is one that derives from identity diffusion, the lack of affect control and impulsivity, and the other symptoms are really, to quite an extent, consequences of these basic failures. And those failures translate into chronic difficulties in the relation to work and profession, love and sex, social life and family relations, and personal creativity. Differential diagnosis. Basically, it is with other patients who present severe personality disorder, and particularly with patients who present, therefore, borderline personality organization on the basis of an extraverted temperament. One neurobiological dimension that is helpful in organizing the total picture of personality disorders is the temperamental question of introversion and extraversion. We refer to introversion as reduced reactivity to external stimulation. And it translates into social tendency to be relatively withdrawn, to be limited in the expression of one's affect, and a tendency to elaborate the cognitive aspects of one's affective reaction. So introverted people tend to be less communicative, less outgoing, but with a more intense life of fantasy in which they deal with their conflicts, real and fantasied, wished and and feared relation with others. Borderline personality disorder is typically presents in extroverted personalities. So the differential diagnosis is with other severe personality disorders that present extroverted manifestations. The histrionic or infantile personality, the narcissistic personality, and the personality features of depressive personalities, particularly bipolar tendencies and hypomanic reactions and exaggerated extroverted behavior during hypomanic behavior that sometimes leads to the diagnosis, to the differential diagnosis with bipolar illness. And the characterological depression that borderline patients experience, chronic anxiety and characterologically based depression leads to the differential diagnosis with depressive illness as well. And that affects particularly the differential diagnosis of patients with suicidal behavior. Finally, the differential diagnosis in practice has to be carried also out with ADHD, attention deficit hyperactivity disorder, because of the impulsivity and distractibility and lack of commitment to work or study that ADHD patients may often present, and quite frequently these are erroneous diagnoses. So we'll study the differential diagnosis with these conditions. First, regarding the histrionic or infantile personality disorder, it really is very similar to the borderline personality disorder. The truth is that the infantile or histrionic personality disorder is a milder form of the total disorder derived from identity diffusion that the borderline personality disorder shows. And we may describe the hysterical personality as the still milder manifestation of the same line of personality disorder. The hysterical personality disorder functions with normal identity. So it's easier to differentiate from the borderline personality disorder than the histrionic or infantile, because they also show affect, discontrol, and all the symptoms really that I mentioned for the borderline personality disorder. But the difference is that histrionic or infantile personality disorder don't have the intense degree of aggression that borderline personality disorder struggle with. They don't show the severity of suicidal attempts, severity of self-mutilating behavior, severity of outbursts and conflicts with others. Borderline patients may, in their angry outbursts, start attacking people, psychological, and hitting them physically. Histrionic or infantile personality disorders don't show that extreme violence. They don't show the extreme of self-mutilation. They have a capacity for maintaining relationship in a more stable way, rather than breaking up all relationship, as is typical for borderline patients. Histrionic and infantile personality can keep themselves in love relations and in work, and are able to maintain a more or less acceptable social life, in contrast to borderline patients where the intensity of aggression threatens the relation with others, isolates them, shows them as severely self-harming themselves, and incapable really of maintaining a stable work situation. So these are quantitative differences, but in practice, if you keep in mind how severe are the manifestations of aggression, if the patient, because of his severe aggressive behavior, is totally isolated, not related to anybody, is incapable of maintaining a long-term love relation, severely self-mutilates, of threatened survival, that's a borderline personality disorder. But if the patient is able to maintain relationship, even if chaotic and problematic, maintain himself in work situation, have some capacity for depending on parents or spouses or friends, in contrast to patients who seem totally unable to depend on others in a stable way, that fosters a differential diagnosis. With practice, that comes easier than you can imagine. With narcissistic personality disorder, it's an important differential diagnosis, because narcissistic personality disorder, as we are going to see when we talk about pathological narcissism, extend along a very wide margin of severity. And the most severe narcissistic patients really are unable to work, unable to maintain any love relation, tend to be totally socially incompetent, suffer from severe anxiety and depression, intense aggression, particularly a subgroup of narcissistic patients who present the syndrome of malignant narcissism, show intense aggression. So and they may present multiple symptoms, same as the borderline personality disorder. The big differentiation is that narcissistic personalities don't have any capacity to depend on anybody else. Their relationships are aloof and distant, and they have an intense devaluation of others and suffer from intense envy. Borderline patients don't have these problems. Borderline patients don't show the intense pathology of envy that's so typical of the narcissistic personality. They don't have a consistent depreciation of everybody else. They oscillate between extreme dependency and extreme struggle against dependency. They are very ambivalent and contradictory in their relations, but they get involved intensively with others, in contrast to the enormous distance that narcissistic patients have with all others. So when you see somebody who looks like a borderline patient, but with intense problems of devaluing of others, showing personal grandiosity, which is also not typical for borderline patients. So a combination of grandiosity, devaluation of others, problems around envy that diagnose and differentiate the narcissistic personality from the borderline personality disorder. Regarding bipolar patient, patients with bipolar illness, in contrast to personality disorders, really have no major problems with others. If you study them outside their hypomanic or depressed episodes, they may have significant relation in depth with others. So a bipolar patient may have terrible periods of major depression where everything breaks down, or manic or hypomanic behavior. But when the patient is out of the hypomanic phase, out of the depressed phase, there is a normality of object relation in depth, capacity for integrated, ambivalent, thoughtful, realistic assessment of others and self in the interaction and in the relationship. So you can discard the personality disorder, the severity of the personality disorder that would be reflected supposedly in patients, at times in patients with bipolar illness. I think the nature of the relationship that the individual maintains is one important difference. And another one is the particular study of the depressive reaction of these patients if they don't have major depressive episodes. So these are two questions we raise with depressed patients in the differential diagnosis with borderline personality disorder. Um, uh, First of all, the severity of the depression. Whenever patients say they are depressed, they seem depressed, you have to study the depressive symptoms. With major depression, patients are deeply depressed to the extent of practically feeling frozen, having no feeling at all. That becomes obvious in the contact. They tend to have depressive convictions that are unrealistic about themselves. There tends to be a daily rhythm, certain hours at which they are more depressed, day after day. So the depression is severe, consistent, and has typical times of worsening. It goes together with self-devaluing ideas that may become psychotic about end of the world or danger to survival. They tend to reduce their capacity to think. They slow down. They may not be able to think, to read, to watch television. And they may show physical symptoms of depression that are pretty typical for major depression. Severe loss of appetite, severe loss of weight, severe loss of sexual function, severe loss of any capacity to see anything positive in their daily life or in their life or their reality. Particularly the severe weight loss, alteration of sleep, severe insomnia, early awakening every day, unchangeability of the depression. These are typical manifestations of major depression. So the intensity of depressed mood, its stability may indicate a major depression. In contrast, characterologically based depression are less intense. Sometimes they permit the patient to go on with a life as always, and other people don't even notice how severely depressed the patient is. The depression comes and goes depending the external stimuli. It might get better over the weekend or worse, better with friends or worse. With major depression, generally when somebody tries to encourage them, they feel worse. Major depressions tend to react getting worse when they feel they are being helped or people are trying to understand them. For this reason, psychoanalytic group psychotherapy is contraindicated in the case of major depressions. So absence of neurovegetative symptoms of depression, irregularity and less severity of the depression. It's not affecting cognitive capacities such as reading, going to the movies, watching television, or maintaining ordinary social contacts. If all of that is lost, then you have to raise the question whether the patient has a major depression. And by the way, if you think the patient has a major depression, then it's important to hospitalize the patient, because then there's a real danger of suicidal behavior. If a patient has suicidal intention and a major depression, hospitalization. Don't run risks. Remember that major depression and suicidal ideation. If, on the other hand, clearly the patient shows a characterological depression, depression is less severe, it's irregular, there are no neurovegetative symptoms. There may be sleep alteration, but they are not that severe. Sometimes there is an excessive sleep in characterological depression. And they are usually able to continue reading the newspapers, maintaining work and ordinary functioning. And the irregularity is what it gives away. Truly major depressions are absolutely regular over many days and weeks. In addition, you have to evaluate the personality of the patient. And major depressions may be perfectly all right outside their depressed episodes, while characterologically based depression typically show certain personalities. They may have, within the neurotic level, depressive, masochistic personality. Within the borderline level, present with borderline personality disorder, or we may present with narcissistic personality disorder or antisocial personality disorder. Antisocial personality disorders also may get depressed. So you have to, the differential diagnosis of depression is crucial in the way you handle this patient. Major depression, suicidal tendency, hospitalization. Major depression, no suicidal tendency, but clearly a major depression. You still may have to get them into a hospital unless you have assurance from features of the personality of this patient that they can be trusted if they commit themselves to not acting on their suicidal wishes. So you can't trust patients with antisocial features, with an antisocial personality disorder. You can't trust patients who use that as a threat or a way to impress the family or getting attention from the family. You can't use it with patients who are impulsive, drug addicted, or have great difficulty in maintaining object relations, don't have a capacity for dependency, and superego failure. In all those cases, you are best off, when in doubt, hospitalize the patient. If you can trust that the patient will follow what you are suggesting to do, then you can continue doing the evaluation on an outpatient basis. But it has to be after considering whether it's safe. If the patient seems to have a characterological depression and definitely is not a bipolar illness, then the indication is psychotherapeutic management, and establishing as a part of the treatment contract how the patient is supposed to manage periods of depression. We'll talk about this when we talk about treatment. That's the differential diagnosis then with histrionic infantile patients, narcissistic patients, and bipolar patients. We are talking about bipolar depressed one. Now I'll go to bipolar hypomanic one again. Hypomanic patient outside that episode may have relationship in depth and not show identity diffusion. So this is, you make the differential diagnosis with severe personality disorder. Now, they may have a severe personality disorder, and so there is no normal period, so to speak, in between hypomanic episodes. And you have to diagnose those, differentiate the hypomanic disorder simply from borderline affect activation. And the criterion that you use for that is truly hypomanic episodes have to last at least 3 or 4 days before you can make the diagnosis. So patient should have had at least 3 or 4 days with a radically different behavior from the usual one, being either elated, happy, and for no good reason, or terribly irritated. He's not his usual self in terms of the degree of emotional reactivity. The patient doesn't show the identity diffusion on structural interviewing, has a relationship in depth with significant others, in contrast to the severity of pathology of personality disorders in their relation with others. So if you have a purely hypomanic syndrome, patient should be functioning okay outside the hypomanic episode. And it is this very episodic nature and the clear difference between the hypomanic episodes and the normal functioning of the individual. There should be a clear differentiation that makes the diagnosis possible. In many cases, that is neglect, and people are diagnosed either as having only a bipolar illness, hypomanic syndrome, or as a personality disorder, and the hypomanic episode is missed, which is problematic because the affective disorder has to be treated with medication. And even while you treat the personality disorders with psychotherapy, if there's a parallel major affective disorders, you cannot neglect, and it has to be treated with appropriate medication that is usually capable of controlling the affective disorder and permit you to concentrate in the personality disorder. Finally, we have the differential diagnosis with ADHD. And again, patients with ADHD tend to have normal relation outside. There are studies in which they show distractibility and hyperactivity, so they are able to have relationships in depth. That's not affected by the inattention as cognitive tasks are. The diagnosis of ADHD in general should be made during childhood or adolescence. In general, when the diagnosis is made in adults, it tends to be erroneous and other things are missed. That has been our practical experience over many, many years. So personality disorders act impulsively with some people with whom they have conflicts and are very well controlled in others. With ADHD, the same behavior occurs with everybody else, inattentive, distracted, even if there's no conflict with the other person. That's different from personality disorders, where the relationship with different others are sharply differentiated. Usually, ADHD should be diagnosable before 12 years of age. Already in late adolescence, one has to carefully evaluate to what extent the lack of interest in the study, the neglect of study, is a symptom of the personality disorder. And the study of identity, the relationship of the adolescent with significant others, the capacity of relating in depth, and differentiated relationship with people with whom the adolescent has conflicts, permit a differentiation from ADHD, in which distractibility is universal and particularly affects relations to work more than relations to people.